Welcome to all who made it through the rain. We appreciate you coming out and fighting the elements. I know it's not easy on a day like today to come, but we really appreciate it. And we think that it's going to be worth your while because we're going to have an interesting program on home health care, something that we all need to know a lot more about as we move forward in life. Issue of home health care, which is going to be pretty relevant, you can see, as we move forward in life. As I said, I think when we got started, we got emails from people, and they kind of ran the gamut of things, from something which was pretty official, where people hired these traditional home health care agencies, to people who hired individuals on their own to do home care work for them. I was going to give you a couple of examples. I was talking about one of our members who was a very elderly lady who has a fractured pelvis, and she's flat on her back for 4 months. And she's in one of these upscale retirement homes in La Jolla. And she is a person who decided that for her, traditional home health care agency was perfect because it was, first of all, incorporated into her retirement home. And secondly, what she liked about it was the fact that because she was flat on her back, she really couldn't do much. And so, because she couldn't do much, she really liked the idea that somebody else was going to be responsible for providing all that home health care. And she made a couple observations that I thought were kind of interesting. One was, she pointed out that very oftentimes her home health care aide wouldn't come when she was supposed to, and she was really happy that she could just pick up the phone and call the home health care agency, and they would send somebody out right away. In other words, there was a replacement player, if you will, on board and ready to come in and fill the place of the person who didn't show up. Or she had occasions where somebody was working there and the person had a personal family emergency and they had to leave. And so once again, she picked up the phone, and no time they had a replacement there to take care of her needs. I mean, she was flat on her back, she needed somebody all the time. So she liked that, and she also liked the fact that even if somebody came that she didn't like for some reason, there was one time she told me there was a lady who came and who was very sick, who had a very bad cold and cough, and here she was flat on her back and was worried about getting sick herself, and so she sent this lady home right away, but she could call and have somebody come right out. So for her, the traditional home health care agency worked just great. At the other end, I'll give you another example. One of our members told us about a situation where his father-in-law, after the death of his wife, was having problems of various sorts. I think he called it multiple disease syndrome, that led his father-in-law to be crying all the time and waking neighbors at night and all kinds of things. So they decided they needed to get kind of a constant caregiver for him. And they went the other route. They began to interview and recruit on their own an individual caregiver, and they had some advantages, they thought, and they had a place for that person there at the house to live. They could also offer them the use of a car, so they could offer them room, a car, use of a car, and access to their kitchens. And so they felt like that was the best solution for them, because it allowed them to sort of take some resources they had and use those towards pay for somebody who they hired individually. And so you had these two kinds of extremes that we saw in the emails that came to us. And that shaped our thinking about what kind of panel we wanted to put together today. Because what we decided was, we started out talking about home health care, and we were thinking primarily about home health care as being medical care. But we came pretty quickly to realize that our program wasn't big enough. We had to think about home health care of the medical type as well as home care of the non-medical type. And so what we did then was put together a panel that reflects those two components of home care, really. And so our first two speakers are going to be people who speak to home health care, that is the medical kind of home health care largely. And our last speaker is going to be a speaker who speaks to us about home care, the non-medical kind. Because what we found in almost all these cases was it was a combination of the medical and the non-medical that really was necessary to provide a holistic kind of home health experience. So that's what we've done, and without taking any more of the time we have to introduce the discussion, let me get started. Our first guest and first speaker is Lori Cooper. She's coming to us from Silverado Hospice, and she's going to tell us about health care in that setting. Home health care, medical home health care. So, Lori.
Thank you. And are you going to do my slides, or do I have something?
No, we got it clear.
Okay, perfect.
You just signal.
Perfect. Thank you. Good afternoon. Good afternoon. Thank you so much for inviting me to speak. Just a little bit about myself. I'm an RN. I've been in home health care, private home health and hospice for probably 20 years. And I'm here today to focus on the home health, as he said, as well as the hospice, okay? But it's really what I'd like to do is I'm gonna present, it's a lot of information he asked me to go over. It's gonna seem maybe a little overwhelming, so we're gonna have the Q&A at the end, and I think you're gonna get the most benefit during that time, and please feel free to ask me any question. No question is stupid, okay? There's a lot to understand. Before I worked with Silverado, I was a nurse advocate. I'd worked with a lot of families. I lived in Rancho Santa Fe, and I had a lot of neighbors that needed care, and I would go to them and just help them navigate the healthcare system. So I'm very familiar with all aspects, and I'm just here to just share what my knowledge is and answer any questions you might have, because it's very confusing and there's a lot of misconceptions, okay? But first, let me tell you, you are always in control of your own health care, right? All right, so the first slide. Next one. Thank you.
Sorry, we have a technical challenge.
That's okay. It just basically is what I just said. There's private home care, which Cynthia, is that your name? Cindy. Cindy's going to speak on, and then Medicare covered home health.
Well, let's just go this way. Let's do this.
Should be able to just get it out.
That's what I did.
That's what we did, but it didn't show.
And you know what, I put it in with you just for the presentation.
Yeah,
rather than
that's
maybe it was
that's
the navigator.
yeah. Let's try it. There we go. Now you can.
Okay, great, thanks.
So private home care, which Cindy's going to speak on later, I'll leave that alone. And then Medicare home care is when there's a medical necessity, and Medicare, which is everyone's benefit over the age of 65, will cover 100%, unless you have a managed care Medicare benefit. Then there has to be a contract, and we can talk about that at the end. It's confusing. I would like to say that if you're able to keep your Medicare benefits straight without being managed, that's the way to go as you age, because there's a lot more benefits when it comes to home health care, skilled nursing, doctor's visits, etc. Skilled services. Next slide. So these are the reasons why you would have home health services. And home health services are anytime a doctor orders home health care in the home, and there has to be a skilled need, okay? So basically, well, we're gonna get to that, I'm not gonna go into that yet. Next slide. Home health care would require homebound status, which means that you cannot leave your home. You can't drive, it's too difficult for you to get out and about. Then we could come in and Medicare would pay for it. A physician would oversee your care, and you would also have a nurse and a caregiver. As Barry said earlier, a nurse will come out 1 to 2 times a week, but if it's deemed necessary, they could come out more. You just have to ask. They're not gonna offer it unless you ask. Again, you're in control of your health care, you can ask for that. Next slide. Okay, this is what I just went over. So there's a skilled nurse, a physical therapist so these are some of the professionals that can meet you at home. A skilled nurse, physical therapist, if you had a hip fracture, something like that, you needed therapy at home and you couldn't get to the outpatient therapy center. Speech therapy is great for people that have had a stroke or someone maybe with dementia that's having difficulty swallowing. Speech therapists, no one thinks of it like that, but they actually work on the swallow reflex. As we age, sometimes that becomes an issue as like a secondary situation. So in addition, an OT is an occupational therapist, social worker, psychiatric nurse, and you can read all those. Those are all part of the skilled services under the home health benefit. But when you decide, or a physician says to you, this is the home health agency that I'm recommending, you might want to ask those questions. What do you provide? Because not all home health companies have all these professionals in place. Very few, actually. Next slide. So the other thing is, when a nurse comes out, they could teach, they could train, they do observation assessment, they have a lot of documentation that they have to do to meet Medicare criteria, and they can also obviously manage and evaluate. Next slide. Medical care at home is again paid by the Medicare benefit, but then, I lost the slide in a minute. Okay, Medicare, Medi-Cal for any skilled need under home health. And then you can also, Barry asked me to touch upon this, but if you don't have insurance or your doctor's saying you don't qualify under Medicare guidelines, you can pay privately for a nurse, and the average cost of that is about $250 a visit, which is 1 hour. They come out to your home, physical therapist or a nurse. The other thing is concierge practices, which Jen will talk about a little bit. There are many concierge doctors in our community that charge a fee, and it's between anywhere $1,500 to $3,500 a year. You have access to that doctor 24/7. That doesn't pay per visit, then you have to pay per visit. So if you have insurance, under that concierge doctor, they can bill your insurance, but there might be a copay. But that's just, that fee is just to cover that 24/7 access. If you're able to afford that, it's wonderful in our beautiful healthcare system today, because it's very difficult to get in to see doctors. It's very difficult to spend time with doctors. They give us 5-10 minutes. So this way, you're going to get a half an hour, an hour, an hour and a half with these doctors. But it does cost. Next slide. Okay, so that was home health. This is another, what they could teach on wound care, injections, infusion. If you're nervous about going home, post-surgery or from the hospital, when you go home, the nurse could teach on all these things. Next slide. We talked about this. Oh, you wanted me to touch upon this, Barry. So some of the reasons why you have home health, after an emergency room visit, after surgery, hospitalization, obviously, after you have had like an acute episode with stroke, heart attack, COPD, respiratory issues, and then also, again, falls, generalized weakness. If there's been a decline in your ability to do activities of daily living, you could ask your doctor for home health care. Just because you didn't have an episode where you've gone into a hospital or an ER, you could still ask your physician, hey, you know what? I think I need home health because I'm unable to get around. I'm in a wheelchair. That gentleman that was here earlier that fell, he would qualify because he's restricted to a wheelchair. he could get physical therapy, nursing. He just had a fall. He could actually call his doctor and have home health come out, okay, to attend to this. That's it. Next slide. Okay, so now I'm going to go in. We're going to save Q&A to the end, right, Barry? Am I going too fast? No. It's a lot to cover. Okay, so hospice. Does everybody understand what hospice is? It's comfort care at home. People think it means it's the end, but actually we've had people on hospice for several years. So the philosophy is comfort care and quality of life. Next slide. That's under Medicare guidelines. People have to have a diagnosis of 6 month or less expectancy. Next slide. And this is your team. It's an extensive team that come out to your home. This is really to support the patient, but more than that, the family. And it can be done, most people think you go somewhere, but no, we come to you in your home, or there are communities, not, years ago there was San Diego Hospice where there was a huge building, like a hospital, that people would go to, but we don't have those anymore in San Diego. So there are facilities that have 6 beds. They're very beautiful. People can go there and have hospice care if they don't want to be home. They can also be in a hospital, or they can go to a skilled nursing facility. But that's the team that supports the patient. Next slide. Okay, so what does hospice provide? First of all, hospice is covered by Medicare 100%. There's no cost to you. It provides every medication related to the diagnoses, that is the terminal diagnoses. So if you had a cardiac related diagnosis that with a life expectancy of 6 months, hospice would cover all of your medications related to that, as well as comfort medications. If someone has a cardiac diagnosis or a, say, COPD, a pulmonary diagnosis related to hospice, and they are on dialysis, they could still be on hospice and go get dialysis. If the terminal diagnosis is related to something other than the kidney failure, people don't understand that. They can continue with treatment unrelated to the diagnoses. So if I had pulmonary disease, COPD, and I also had cardiac issues, I could go see my cardiologist and still bill Medicare for that. I could not go to my pulmonologist because hospice is overseeing that care, and they're billing Medicare for the pulmonary related treatment.
What is DME?
I'm sorry, DME is durable medical equipment, so that would be, thank you for asking, that would be a wheelchair, walker, bedside commode, hospital bed. Any supplies needed, hospice would pay. Next slide. That's really the goal. When we see patients on hospice, they don't want to go back and forth to the hospital anymore. They're tired. It's just a poor quality of life. They just want to be home and be treated for comfort. So we go in. Next slide. That is hospice, focusing on comfort, the family, patient, and controlling of symptoms. Next slide. Okay, this is something people think when they think hospice. Hospice comes in, they give them medication, and they pass. That is not true. We do not hasten the progression. We actually have seen many patients bounce back. We call it rebound, and they end up coming off hospice. We call it graduating. And then we call in home health to support them, or palliative. But that happens more often than not. Next slide. Again, who covers Medicare, Medi-Cal, TRICARE, private pay. Here are some myths related to hospice. Next slide. Hospice is for the last few days of life, not just for cancer patients. Going on hospice means giving up. Patients can no longer see their doctor. You can absolutely see your doctor unrelated to the diagnoses. If the patient lives longer than 6 months, they will be discharged. That's not true. If they still meet criteria, they can continue in hospice. Hospice is a benefit that we all pay into. And the thing is, my dad just passed a year ago, and without a hospice, it would have been a tough road. It is really, again, to support the family, and it's a benefit. So I can't say enough how important it is. Another myth is patients that are no longer on hospice can no longer seek any curative treatment that are on hospice. So again, if you're on hospice for, again, pulmonary, you can go and get dialysis. Does morphine hasten, do we give them morphine to hasten death? No. And then the last is hospice is for people who don't need a high level of care. That's not true. Okay, this is our next slide. Why Silverado? I'll put a plug in for Silverado because of what we do. 7 and 7, Medicare guidelines state that hospice companies only have to send a nurse like once every 2 to 4 weeks. That's the guidelines. Our philosophy is twice a week. We go out 7 days in 1 week. So we have someone out there every day for the first week to support the family. That is a nurse, a caregiver, a social worker, a doctor. Physician does not need to go out, but within the first 60 days of treatment. Our philosophy is best practice once in the first week. Essential oil treatment, doctor-driven program. Memory catchers is beautiful, especially for our dementia families that have loved ones with dementia or Alzheimer's. We put together videos of memories for the family. Bereavement counseling goes during the hospice time, but also after the patient passes. We're with the family for the next 13 months if they choose to call us. And then also, we just enhance quality of life for the family. So next slide, hospice versus palliative. Am I on time, Barry, or am I running over?
Okay.
Hospice versus palliative. This is confusing. Most people think palliative means hospice. It doesn't. Hospice, it says Snoopy. This is so cute. Someday we all will die. And then Snoopy says to Charlie Brown, true, but on all other days we will live. We will not. We will live. So it is true. So palliative is supportive care. Next slide. This is for people that have terminal diagnoses that are not ready for hospice. They just need extra support at home. Certain insurances will pay for this. Medicare does not pay for it yet. Medi-Cal does, which is interesting. But you can pay privately as well. The beauty of palliative care, which is a support team, it's a doctor, a nurse. They are available 24/7. They don't go see you 24/7, but if there's a need, they will go out to your house. You can continue with home health. That's huge. So you can have all that support at home. So palliative versus hospice is hospice, there is 6 months terminal diagnoses. Palliative is, it's a terminal illness. You can read all that. Next slide. This is what palliative team looks like. Basically, oh no, this is, the team is the nurse and the doctor, but this is what the palliative team will be doing. Med management, symptom control, 24/7 access. They become your 911. And then advanced directive and pulse, they get all that set up with you with their social worker. So it's a great benefit. Who can be on palliative care? Anyone with a chronic illness, dementia, COPD, cardiovascular disease, stroke, Parkinson's, ALS, kidney disease, anything that's a terminal illness. Anyone that's been having a decline, they've been going back to the ER on and off for months with UTIs, urinary tract infections, pneumonia, any type of infection, sepsis. If they keep going back to the hospital, you qualify for palliative care. Weight loss of greater than 10% in the last 3 months. And anybody that is needing more assistance, those that are going from, you've been walking independently, then you're using a wheelchair or a walker. You're having need to have help with bathing, walking, dressing, meals, things like that. If there's a decline noted, they qualify for palliative care. Who covers palliative care, and can palliative and home health run together? I said this. Yes, Silverado Palliative Care is covered by Blue Shield Promise, Medi-Cal, not Medicare yet. Yes, you can be on palliative care and also be on home health. Medicare bills separately. The benefit of both is combined care. It's just more care. Oversight of medication, your care plan, communication between your primary care doctor and your palliative team. Again, I can't say it enough. As you age, you just need more support in the home. You can keep your attending physician as well as have a palliative physician and or a hospice physician. People think they have to give up their doctor. They do not. Okay, next slide. Barry, you asked me to cover a lot here. I'm trying to get through it.
No, let's do this.
2 more slides.
Okay. Okay.
Is this good?
Yeah.
What is the End of Life Option Act? We'll answer these questions at the end. This is new to California, June 2016. It's a new law here. It allows terminally ill patients to request a drug from the physician that will end the patient's life. Participation is completely voluntary. Doctors and other healthcare providers may choose to opt in or opt out. They do not have to do this. Doctors and other healthcare providers are insulated from any potential liability if they choose to opt in or opt out of the law. Cause of death on death certificate will be the patient's underlying terminal illness. It will not be suicide. Life insurance will not be affected, neither will estate planning. Last slide. To receive the aid in dying drug, a patient must be 18 years of age. They have to have a terminal disease. A physician must determine that the disease cannot be cured or reversed with an expected death within 6 months. Have the capacity to make medical decisions. Someone on dementia is not allowed to do this or have that in their history. Or mental illness. Nothing, they cannot have impaired judgment. So any mental illness diagnosis, they don't qualify. Have the ability to physically and mentally take the drug at the time. Only the patient can take the drug. A nurse cannot administer it, a doctor cannot administer it, a family member cannot administer it. Only the patient has to administer it. Healthcare agents, surrogates, and conservators cannot request the drug for a patient, and you cannot place it in advance directives. Okay? And that is it. Thank you.
Thank you very much. We appreciate your talk, and we're going to have lots of questions for you, I'm sure, at the end of the program. But if we do them now, we'll never get to the end of the program. So we're going to hear now from Jen Durant, who's with Integrate, works with Dr. Bob, who we've seen here many times, but okay, go to it.
Hello, I'm Jennifer, and I work with Dr. Bob Uslander at Integrated MD Care. I understand I have a soft voice, so if you can't hear me, just raise your hand and I'll speak up. Okay. So I met Barry at a friend's house, and we were talking about my experience as a hospice nurse, and I was giving him the inside scoop of what patients and families believe they get with hospice, what they believe they don't get with hospice, and what actually happens. And so he talked me into doing a presentation for you all today. And so this is my first time, so bear with me. I'm here because Barry asked me to. So I've been in healthcare for 18 years, and the last 8 of those years have been in hospice and palliative care. I've worked with 4 different hospice agencies as an admissions nurse, so I'm very aware of what qualifies a patient for hospice and what you can get under the hospice benefit. Granted, I've been out of hospice for 2 years, and policies and procedures change all the time. So some of my opinions may be a little outdated, but overall there's some overarching truths that we're going to discuss. So So understanding hospice and Medicare, Lori touched on this. It's a government program, and as such, there are many rules and regulations governing hospice and who can qualify for hospice and what hospice agencies can provide. Let's see. She talked about the general admission guidelines, so having that terminal diagnosis with a life expectancy of 6 months or less is the key for a hospice admission. In order to stay on hospice, you also have to have documented continued decline according to Medicare guidelines. So a patient can be slowly having some changes, but essentially if they're not staying ill enough or declining quick enough, they may be looking at hospice discharge, which is graduation, which isn't always a bad thing, but then you do lose that support of hospice. Hospice is covered 100%, and as such, there's also considerations by hospice that, as any business, there is a bottom dollar, and hospice receives a daily rate from insurance companies, from Medicare, Medi-Cal, that they have to take into consideration when they're providing hospice care for patients and families. And as Lori mentioned, Silverado does things outside the box of Medicare, above and beyond, as do some other agencies, and some don't. Some are more interested in paying their upper management to keep them on board and using funds in a different way. Most hospice agencies are in it for the heart of hospice, and they take that daily rate and put it back into patient care, back into appropriate staffing ratios. So it's important to ask when you're interviewing hospices how they like to spend their money, essentially. So, as I said, not all hospices are created equal. And a lot of people believe that you have to sign up on the hospice that you've been referred to. And that's absolutely not true. Patient and family have a choice as to what hospice agency they'd like to use. A lot of referrals are driven by who knows who, not necessarily who provides the best care. So keep that in mind, as if you receive a hospice or home health, any sort of referral, it is based largely on the representative going out to see the doctor or the social worker and bringing them lunch and kind of schmoozing them and making friends with them, and that's how you get people to refer to your company. Other places like our practice, we will choose to refer to companies that provide great care because they're an extension of us, and if they don't do well for our patients, that makes us look bad. And we really want our patients to receive the best care possible. So after you've been referred to hospice, you can ask for a list of hospice agencies. You can do your own online research. And I also suggest that people ask for interviews with family members that have had their loved one on hospice, and even with the hospice nurses to see what kind of care they provide, what they think of their company, what the family thinks of the care they've received. Just ask a lot of questions. So some other things to consider and ask about when choosing a hospice agency are the staffing ratios. As I mentioned, some hospices, everyone will be assigned a nurse case manager that's in charge of your loved one's care. That nurse may have 15 patients, that nurse may have 25 patients. For some hospices, they're perfectly fine with their nurses having 25 patients, which is very unmanageable. It's very busy, and if you try to call your nurse case manager, it's not likely you're going to get her on the phone or him on the phone very easily. And it also increases the number of different faces that you'll see because your nurse will be overwhelmed, so they'll send an LVN out to make visits, or they'll send a different RN out to make visits. If they have a lower staffing ratio, it's easier for the nurse case manager, who will be the point person on your hospice team, to be more intimately involved and be more available. It also can lend to nurse burnout if they have high staffing ratios. And so your poor nurses are working all day seeing patients, and then often we go home at night during our free time and do the mountain of charting that's required by Medicare to make sure that we're meeting guidelines and that hospice is getting paid that daily rate. So ask about those staffing ratios, it's really important. And one of the benefits of hospice is that they cover the medications related to the terminal diagnosis. They provide equipment, and some even provide those extra services such as aromatherapy, music therapy. Some have a volunteer staff that come out to support patients and families. There are certain cases where you're on a medication related to your terminal diagnosis that they will ask you to stop. So that's another question you need to be aware to ask your hospice rep when they talk to you. For example, there's some oral chemo medications or other medications meant to slow the progression of cancer that can be considered a palliative treatment. But under the hospice Medicare guideline, Medicare says we will not pay for these drugs if someone's on hospice care. If you do have kidney failure and you are getting dialysis, and that's what you're being admitted to hospice for, you will be asked to stop dialysis. Depending on the hospice, either you can be admitted and continue dialysis for a few more times, in my experience, or the hospices I worked at, Medicare said we will not pay for dialysis for someone coming on a hospice, which means once you stop dialysis, you have 3 to 5 days to live. So it's really important before you sign those papers to make sure that you're going to continue to receive the care that you want to receive, or that you're ready to let go of that and you're ready for facing end of life. Another consideration when looking at hospice agencies is asking them how long they've been in business and how big they are. Just because they're new or old doesn't make them any better, but it's something to consider. Bigger hospices have more resources, they have more staff. It's easier to get nurses out to see you quickly. They can be a little bit like a people farm or treating you like a number, and it can be impersonal. Smaller hospices can feel more personal, but they may have lack to access of resources and staffing to be able to get nurses out quickly. So as you're interviewing them, consider what your needs are and take those into consideration. Some hospice agencies do provide what they call early access programs or palliative programs, which are for patients that aren't quite ready for hospice care, especially looking at those dialysis patients. They don't want to stop dialysis yet. Some agencies do have sort of a bridge program. So that's another question you can ask, is if they have a palliative or early access program. So you can continue those treatments until you're ready to stop or until your doctor says these treatments are no longer effective. You can also do just straight palliative care. It doesn't have to be associated with a hospice agency. So one of the benefits of hospice is that there's a nurse on call 24/7. You have access to a medical team. If you're in crisis, if you have a question at 2 o'clock in the morning, there's a nurse on call that you can have access to and ask those questions or get help when you need it. Some agencies use an answering service, so you're leaving a message for the nurse on call. So one question to ask is if the agency, if a nurse is answering the phone or if you're leaving a message with an answering service and waiting for a call back. If it's a routine question, it's not a big deal. If you're in crisis, it's a huge deal. It's a huge deal to be able to have a nurse on the other end of the line when someone's in crisis, and you can get help and direction over the phone right away. The triage nurse is not typically familiar with the patients or the cases individually. They may be in smaller companies, Some of the bigger companies even outsource their on-call nurses to other states, so they're not even here, which they're helping over the phone. It's typically not an issue, but it's just less personal. And a lot of people believe that once you call, there's a nurse available all the time and they'll be right out. That happens once in a while, but typically a lot of families wait an hour, sometimes more, depending on how busy the hospice is, to have a nurse out there. And if there's an urgent situation happening and you're waiting over an hour, it can be pretty scary. So all important questions to ask: are we calling an answering service, or are we calling and talking to a nurse? And what's your typical wait time when we call with an urgent need that a nurse will actually be there in person? Under hospice care, you do have the option to keep your doctors. And if it's not related to your terminal condition, you absolutely can see your doctors. Some patients try to keep their primary instead of using the hospice doctor, which sounds nice because you have a relationship with your primary care doctor. They know you. The downside of trying to keep your primary care doctor as the hospice doctor is that it's hard to get a hold of them while they're in clinic and seeing patients. They may not be on call after hours. A lot of them aren't trained in hospice and end-of-life care, which is why they made the referral. And so when the hospice nurse is trying to get a hold of your primary care doctor for orders, it may delay care while we try to get through to your primary care. They can use the hospice doctor as backup. So just another thing to consider if you want to try to keep your primary care as the hospice attending, or to use the hospice doctor. So when we choose to use the hospice doctor for the hospice care, there is typically a really quick response from the hospice doctor because that's his job or her job. And they've been trained in hospice care, so they know how to manage. One downside is that they're not very familiar with your loved one or their case and what's going on, and they rely heavily on the information they're receiving from the nurses, which nurses are wonderful. We do a really good job. But it is less personal, at least from the doctor, because he's not highly involved in the care. They do go to meetings about every 2 weeks. They have patient care conferences internally in hospice, where the doctors are updated on all the cases. And occasionally a hospice doctor will go out to the house. In my 6 years of experience, I saw it twice. Sounds like it's a little different at Silverado. They send them out, in the first week for a visit. And another option, as she mentioned, is to hire a palliative care doctor or a concierge doctor who is trained in palliative and hospice care, and who can be more intimately involved in the care of your loved one than a hospice doctor can. Hospice doctors are limited by the rules of Medicare and what Medicare will pay. They won't pay for a doctor to go visit every day. So hospices need to work within those guidelines. In my limited understanding of palliative care covered by insurance, it covers a doctor visit once or twice a month, and you have access to call in if there's any questions. You can also private pay for a concierge doctor who you have 24-hour access to, and will visit more often because they're concierge. You're paying out of pocket. They're not limited by the mandates of Medicare or any insurance. So if you can afford it, it's a really nice way to go, because you truly do have 24-hour access to a doctor, and you get a lot of home visits. Another option is to pay a concierge medical team like Integrated MD Care. So I will do a shameless plug for us too. So at Integrated MD Care, we provide concierge palliative care, not just for people with a terminal condition or terminal diagnosis, but anyone trying to recover from surgery or with an acute injury, all the way up to end-of-life care. And because we're private pay, we can provide that high level of touch in-home care. I typically visit a couple times a week and will visit daily if needed. The doctor will visit at least weekly, and we're both on call 24/7, and we're a small team, so we know every case. We're intimately involved and aware of what's going on, not only with the patient, but the family. Most of the care, as Lori would agree, is for the family and support. Another option that people aren't typically aware of is hiring a nurse case manager. And this works really well if you're not quite ready for hospice. The palliative doctor visits once or twice a month, but you need just more oversight and management of finding caregiving resources, help finding equipment resources. A nurse case manager, it's just a nurse, and she's typically not practicing any clinical. She's not coming to check vitals and do dressing changes, but she helps oversee and manage your overall care. She'll help make doctor's appointments, help find transport to appointments if that's what's needed. It's sort of like having a really involved family member that knows all the community resources. So that's another nice way to go. If you just need a little extra help, is to get a nurse case manager involved in your care. So some of the benefits of hospice care are that it is covered 100% by Medicare, Medi-Cal, and most insurances. So you don't have to pay out of pocket like a private concierge medical team. And there's easier access to medical staff. They have someone on call 24/7. There's a higher level of involvement. You get the support of a hospice doctor, hospice nurse, a team of on-call nurses, a home health aide to come help with bathing. There's chaplains and social workers and bereavement support. So hospice really is a wonderful program. And like I said, some have additional programs such as volunteer support, aromatherapy, music therapy, the bridge programs like a palliative program for people that aren't quite ready to start hospice yet, or an early access program. But it is important to be aware of which hospice you're choosing and choosing the best one for your loved one. You can also change hospice agencies at any time during care. Some people think that they have to stay with the original agency that they signed up with. That's not true. You can change any time, but it is a little bit of a hassle. But if you feel like you're not getting good care, you can elect to change hospice agencies. So some key points when considering hospice care and considering an agency is that educating yourself is key. Asking all those questions, really asking about the staffing ratios and how long they've been in business and what they cover. Some agencies will even cover medications that other agencies won't. Some will allow IV hydration and some won't. So it will be really specific to what's going on with you or your loved one. Anything you want to keep or get rid of, you'll want to make sure that the hospice is supportive in that. And if they're not, there's plenty more to choose from. And you can keep interviewing until you find the right fit. If you have a concierge medical team or a nurse case manager, then they can also make suggestions. So the biggest thing to consider when you're thinking about hospice is if you're ready to fit into the hospice model. Because it's run by Medicare, they have to abide by the rules and regulations. So if you're ready to go that route, hospice is a wonderful support. If you're not ready to go that route, you can consider palliative care, nurse care management, or private pay care. And maybe you'll realize you don't need help at all, and that's okay too. So just really educate yourselves and educate your loved ones about the decisions you're making, and realize that there's more to choose than hospice. You can have the palliative doctor in addition to hospice. You can have a nurse case manager in addition to hospice. You can have all three of these combined. So don't limit yourself when you're looking at hospice. Remember, there's other resources to supplement hospice and potentially replace hospice, not replace hospice care, but if you're not ready for hospice, you can choose these things before signing on. If there's any questions, we'll address that afterwards. Thank you.
Okay, Cindy Wilson, I'm with a company called Heritage Senior Care. I've been with them about 16 years, so I've seen a lot of changes, and most of the changes have occurred in the last few years. One thing I want to mention is that, you know, a lot of times we get our information from talking to other people, but one thing you have to realize is that everything is different state to state. So California is unique amongst itself, and so, go to the first slide. So before 2016, and this is very hard to believe, I'm sure, but before January of 2016, the home care industry was not regulated. And so that's a pretty scary thing, because if you wanted to take your, you know, dog down and have him bathed and you know, prettied up, yes, that's a licensed industry. But home care, surprisingly, was not. And there were a lot of great agencies that worked with large trade associations and created levels of standards. However, we did not have the enforcement, because when you don't have laws governing an industry, then you have nowhere to report any wrongdoing. There's no oversight. So we had about between 700 and 800 agencies in San Diego that were soliciting for non-medical home care services. So caregiving services, when you wanted to hire a caregiver in your home. In January of 2016, we have the Home Care Consumer Protection Act that went into effect. And we went from that large number of agencies to about 90 agencies the first year that actually had the license.
Next.
Yeah, next, okay. Okay, so in the state of California, who is responsible? Who's the employer? Who do you think the employer is for your caregiver?
You are.
Okay, so if you're using an agency, the licensed agency is the legal employer in the state of California. In California, it is an employer-employee relationship, okay? So if you hire privately, a neighbor, a friend, then whether you know it or not, you are still the employer in the state of California, and you're still liable. If you go to your attorney and you draw up a contract and you say, you know, this caregiver is going to be a 1099 and they accept that responsibility and they're going to pay this, this, and this, and do this, this, and this, and you both sign it and you both agree to it, that contract is not legal because it breaks our laws. And so therefore, you know, 1099, a caregiver is misclassifying a caregiver. So I have some information in the back, and the first one you can pick up is this form right here, and it's on from EDD, and it's on the 10 most common reasons why families thought it was okay to pay or hire, you know, a caregiver as an independent contractor, and this would be misclassifying them. Okay, so now the next. Okay, so when we got our licensing involves that on all our print material, we have our home care organization, so HCO number, given to us by the Department of Social Services. So let me just explain how things worked prior to licensing. So prior to licensing, we would have a caregiver come to us and they say, we want to work for you as a caregiver. So then we would put them through our orientation and we check their references and DMV record, and we would have them fingerprinted and life scanned, which went back 7 years, okay? And if they passed everything, remember it's our liability, our insurance, you know, covering everything that goes on in the home. So therefore, it's very important to us that we have the high quality that we're looking for when we hire help in the home. Okay, once licensing went into effect, what happened is the state of California created their own background check bureau. So now, if someone wants to come to us and work as a caregiver, we cannot hire them. They first have to go online to the state of California and pay a small fee, I think it's $35, and then they have to apply to be a caregiver. And then California sends them to be fingerprinted through their background check bureau that they created, and it will go all the way back to 18 years old. And so, so then they go through the bureau, and then once they've passed that, then they get a independent number, caregiver number, which says that they can work as a caregiver in the state of California. Once they are authorized to then provide that care, they can now come to a facility, a community, a boarding care, a home care agency, and then apply with us to be a caregiver with our agency. And then we still do our same due diligence, we still do our own background check, DMV records, you know, references, you know, training, skill level. In our licensing though, these are the requirements that we obviously have to have. So workers' compensation, employee dishonesty bond, general and professional liability insurance. We're all mandated reporters of abuse. Background examinations, TB checks, training requirements. So the caregiver must complete 10 hours of training before they can actually work with a family. And that's in addition to whatever training they may already have. They still have to complete the requirement. Okay, so, and then we notify them when they're no longer. Every year after that, they have additional training requirements. Next slide. Okay, so has anybody heard of IHSS? Okay, so, and I want to bring this up because you know, we talk to each other, right? And I'm telling you something, and then you go talk to your neighbor, and they're saying, no, that doesn't, none of that's that, right? Okay, IHSS is in-home supportive services. Our tax dollars are paying for this program for our low-income seniors who want to stay living in their home instead of being moved to a skilled facility. So what happens is this program, because it's our tax dollars, is a whole different model amongst itself. So the family is the employer, the caregiver is the employee. However, they are carved out of most laws governing caregiving services in California. And so they don't have the requirements a normal licensed home care agency or community or facility would have upon hiring that caregiver. And so they also don't have the training, and of course they don't have the oversight, and of course the person that is paying the wages would not be the family who is the employer. It would actually be our tax dollars. So it's through the in-home supportive services. So our county is paying for those caregiving services. So in order to qualify, you have to be low income. You may have a lot of need, but that doesn't mean you necessarily may see the hours, because it's our funding that supports it. And several years ago, they were almost going to eliminate the program, and so most of the hours were cut, even though they had high care needs. But so I just wanted to at least make you aware of that program. Again, it's only for the very low income, to help them stay in their home longer before being placed. Okay, so that's your in-home supportive services. I don't want to spend a lot of time on this. Go to the next one. Okay, so remember we had 700-800 agencies before our licensing? What do you think happened to all those agencies if we're down to 90 that first year? What happened is they changed their model. They said, hey, you know what? Registry, the industry of a registry, is not licensed. No oversight. So the majority of those agencies either went underground or they became a registry. And a registry does not employ the caregiver. So they can have a caregiver come and join their registry, and they may act like it's their caregiver. They actually say, you know, our caregivers, but it's not their caregiver. They're a registry. And you may not be aware of it when you're hiring through a registry. You know, they'll talk about they've given them training and they're gonna send people out to your house to interview, and you think great, but what you don't realize is that a registry does not have a license. There is no oversight. There is no one to complain to or that can govern them. And then, of course, whether you know it or not, you're the employer, and that brings up a lot of issues later. The red flag that sends up a red flag is always price. And you know, it's pretty much the same, I mean, industry standard, you're gonna see pretty much, there's a average price for most of the products. You know, when something's way out of that normal price range for those services, that's your red flag. And so your registries will say, oh man, licensed agencies, you know, they're ripping you off, you know, we can give you a caregiver for $16 an hour, $18 an hour. Well, home care right now, does anyone know what home care is running right now? 25, right? About on average, 25. $25 an hour for a licensed non-medical. Now, I want to say non-medical. Again, there's a sheet back there. It looks like this, and you all can get a copy of this. And I want to mention this because a lot of people think $25 an hour. You should be giving me shots, and you should be doing this and changing that. And there is a big difference between medical, skill level, and non-medical, okay? So licensed home care is non-medical. And our license will be taken away if our caregivers were to provide skilled services. So what's the difference? Well, the Department of Social Services creates a fact sheet every year since licensing went into effect to help explain to people what they may get confused on. And in April of 2017, so 2017 fact sheet was all about what can non-medical services, what does that look like, what can they do? And then at the bottom section, it's skilled level, okay? So what we cannot do. And on the back, the 2018 fact sheet, 2019 hasn't come out yet, 2018 addressed that employer-employee issue that we were just talking about. All right, so real quickly, obviously registries, they're not saving you money. If you don't pay your taxes, there is no statute of limitation, right? I mean, if you don't pay taxes, there's no period of time that you can, right, expire. No, you are always liable. So therefore, it involves a lot of penalties and fees when these families are then brought into court for wrongfully not providing the employment responsibilities to their caregiver that they owe. One thing on licensing is, and there is the website, ccld.ca.gov. And that is the website that is through the Department of Social Services. Anybody that has a license is there as far as caring. So if you wanted to find adoption, you know, RC, boarding cares, RCFEs, you know, any licensed. So home care would be one of the categories that is going to be found on that website. You have to maneuver through the website to look for home care organizations, but you can actually put in the name of the agency. And what I do is I tell everybody, click, don't put in the address, click San Diego. It asks you for the county. Just put in the name and the county. Because if you, and then you search, and when you do that, if it comes up with no found agency, but you know that they have a license because they told you they have a license and their business card has a license number, right? What that means is they are licensed. Their agency does have a home care organization license. But when California gives you a license, it's a license to provide services in California, anywhere in California. So when you have a licensed office in LA, and you come up here and you create a sub-office which can have no legal documents, no records, no financial information, nothing in that office. Strictly used to perhaps interview caregivers or store some marketing material. That's important because I have seen agencies from other counties come up here and actually run an office as if they were licensed in our county. So everyone realizes the importance of having our documents stay in San Diego if we're living in San Diego, right? We want our money, our economy, the money to be put back into our San Diego economy. We don't want our money to help the LA economy or anywhere else. So one of the things you want to make sure is that you are using a home care agency that actually has a licensed office in San Diego County, okay?
Excuse me?
Yes.
Could you please repeat the website?
Yes, it's CCLD. It's Community Care Licensing Division, so ccld.ca.gov.
Thank you.
So when you go to it, you're going to see, you know, all the different options, but you want to click through. And I don't know if anyone has ever done that. If you've ever wanted to look at the record of a community, you want to check out, see if they have any citations, right? When you go to that website, you can put in whatever community you're evaluating. And at the bottom of that page, it'll tell you when their audits were and if they were hit with any fines or any citations. We have the same thing on our page. So when you find your home care agency, if you scroll down to the bottom, they will have our audits are once every 2 years. Communities, it's once every 7 years. But if there were any fines or penalties or citations, it would be noted at the bottom, okay? Okay, next. Oh, keep going. All right, so we sort of went over that. Next one. Only because this is a lot of information. Okay, so the training for the first year, this is some of the, and Barry, you can send them this PowerPoint presentation if you'd like, so don't worry about reading it all, but this is just 10 hours of mandated training and what it covers. And even if they are a CNA or we hired a retired nurse, they still have to go through the training again. Okay, next. Okay, so challenges. Let me talk real quickly before my time runs out on paying for home care services, right? Good news, there are a couple of programs. Bad news, it doesn't cover it for everybody, but at least I want to let you know what programs are out there that will help cover the cost of home care. Now, we are seeing some HMOs are picking up a few hours in your insurance program for the year. So some will offer 30 hours a year of licensed non-medical home care. Well, 30 hours is not a lot. Maybe if you had knee or hip surgery, that would be helpful. But if you have a chronic disease and you're caring for your loved one at home 24/7, that 30 hours won't even, help a lot. All right, so the first, and this brochure is in the back, that we work a lot with the VA. And so this program is called the Homemaker Home Health Aid Program. And this program is funded through the VA, and it is for combat veterans, okay? So, they do not, this is like the cherry on top of the sundae. They do not care what you own or what you have. There's only one requirement, and that's pretty much that you were a combat veteran. And so, what you do is there's the gals that run the program inside, and so you will see one of the VA social workers who will qualify you for the program and then send your information over, and you can get, if you're caring for a loved one who served as a combat veteran, up to 12 hours a week of licensed home care. That's 48 hours a month at $25 an hour. So that's a lot of money. They're looking for those with high care needs. So the wife that's taking care of the hubby with, Parkinson's and dementia, and they're trying to help. Now, the good thing about this program is that it doesn't matter what else you have. So if you have IHSS, great. If you have aid in attendance, no problem. You can have whatever you already have and this too, okay? The next is aid in attendance, pension, and that's a little more complicated, but I just want to make sure all of our widows and our veterans know about this pension. I was an ombudsman, and I'd go see this little lady in her board and care, and she'd been there 6 years, and money was running out, and that's all she could think about is, how am I going to pay for my care? And I look up on the wall, and there is her hubby in uniform. He's been gone 20 years. And I said, did he serve during wartime? Yes. Was he honorably discharged? Yes. I said, do you realize you're his widow? And there is about $1,300 in benefits that you can get to pay towards your facility. She could not believe it. 4 months later, they sent her, this big giant check, and she could sleep better at night, okay? Would have been helpful if she knew that 6 years earlier, okay? One thing about the program is, especially the low income, okay? I think the people that need it the most sometimes don't get it. Okay, so I'll tell you another story real quickly about a widow, and she told me, I don't qualify. I went down, I don't qualify for the benefit. And I'm like, you don't qualify, what's the problem? And she said, well, you know, he served during wartime and he was honorably discharged, and I have a need, because it doesn't kick in, which is why most people don't know about the program, because it's not gonna kick in till you have a need with 2 tasks of daily living, okay? But she has a need, and, okay, so then the next thing is, well, I live on $1,200 a month Social Security. And I said, okay, and the problem was, when they ask her income, they want to know of her income. How much of that is she paying towards care? Well, what is she going to say? I gotta live. I have rent, I have food, I have meds, I have transportation, I have phone bills. There's no money left, but I need a caregiver, okay? She doesn't qualify. Because it's like a lot of insurance plans, you have to show them that you are paying for the care. And then they reimburse you, and then once you're in the program, it comes every 30 days. Okay, so the solution to that is we work with a VA accredited financial institution, and what they do is they help her do her paperwork, and see that she qualifies, and then when they send the paperwork to the VA, they call us up and say, on her behalf, now start providing these services. So they send the bill in for the services. She now qualifies. 4 months later, a retroactive check will go to her, in which time she then will pay for those services. Okay, and why this is important, because what I hear all the time, and I'll wrap this up, what I hear all the time is, I can wait, I can wait. I got arthritis, but I can't put my clothes on in the morning, but I'm gonna wear something that I can get into. So their life starts to shrink and isolate as they do less and less, instead of just asking for the care. And I tell people, if you qualify, get the benefit now, and I'll tell you why. We don't know what tomorrow is going to bring, right? If this widow did not apply for services and then ends up in the hospital with a stroke or something that does not allow her to return back to her home, she has a higher care need and must be placed, trying to find a facility that will take her on $1,200 a month is impossible. And that's our dilemma with our system right now for long-term care. If she had $1,300 plus to $1,200, she's got $25, it'll be tough, but they'll find her a facility, okay? And just a little plug for hospice real quickly. I was a long-distance caregiver to my sister in LA. And she had cancer, it had paralyzed her, so she was bedridden, incontinent, a lot of pain meds, and she ended up back in the hospital for pain, to manage her pain, and she was in the hospital more than 7 days. Once you're in the hospital more than 7 days, the community doesn't have to take you back, the skilled doesn't have to take you back. And she was very costly. She had incontinent issues and all kinds of problems, and so the problem occurred that the social worker at the hospital, once the insurance stopped paying the hospital, they could not place her. No one would take her because they were being reimbursed, I think they said $105 a day from Medi-Cal, and her care needs were very expensive, so no one would take her. And we ended up saying, okay, if we put you on hospice now, the hospice picks up the cost of the meds, the incontinent products, and it helped, and we were able to find a skilled that then would receive her as a hospice patient. One quick note, that doctor did call me up and say that the insurance wasn't paying the hospital anymore, hadn't been paying the hospital for 14 days, and they could not keep her there any longer, and that they were gonna that doctor was gonna put her in an ambulance and send her down to my doorstep in San Diego and drop her off. And of course, I mean, I don't know a lot about the industry, but I know a little. And I said, oh, no, you're not. And so having somebody that can help you in your time of need is huge. And the person that you would want to be looking for is a geriatric care manager. And you touched on it basically when she said a nursing care manager, right? Okay, so what she's referring to is a geriatric care manager. And there is a certification for that. I have, well, because I'm in the industry, I do have a friend, and she's a geriatric care manager. One little note on that, ask their background. Do they come from a medical background? Do they come from a social worker background? Okay? Huge as far as the cost to you. If they come from a medical background, then they understand what the doctor is saying, and they understand the medical records. If they come from a social worker background, a lot of times they need to then consult with a medical person in order to help and assist. So it adds more cost to the program.
As you can guess, Cindy's limited. I want to make sure you guys have time for questions. So without any delay, shoot, tell me who you want the question to go to. And we have a couple of mics here. Maybe Bob can grab one and Will can grab one. And that way we'll put a mic to your mouth so everybody can hear your questions. And we'll go from there. First question, I see somebody in the back here. Yeah, Ken wants me always to remind people that we're videotaping, and if you don't want to be videotaped, don't ask a question, okay? Or ask it privately afterwards. Yes. Turn it on.
Testing, can you hear me?
Yes.
I serve on the IHS Advisory Board, and we have 30,000 participants attending for the members of IHSS. They do
It has to be turned on and close to your mouth.
Okay.
Okay, thanks. Anybody else have a question? This gentleman over here.
On hospice, for-profit and non-profit, it sounds like, since both kinds of hospices exist, that your best bet would be to stay with a non-profit, because the profiteers are going to want to save money and give you less service in order to make a bigger profit. Is that true? And how do you rate profit versus non-profit hospice?
That would be, I would say, Lori or Jen, maybe?
Both speak to it. Well, there's, how many more?
Let's get the mic. Let's get the mic. There's a mic for you.
So in my experience, which is very limited with the nonprofit and for-profit, I worked for a for-profit hospice, and they were very conscientious of using the profits they made to put back into patient care programs, which smaller nonprofit hospices could not afford to do on the Medicare daily rate. And there are some hospices that have foundations. The for-profit had a foundation through which they fundraised to pay for these programs. And I don't have much experience with nonprofit other than working for one, and they seem to not have as much funding to put back into the patient programs.
So to conclude, it sounds like maybe it's not so easy just to make the choice based upon whether it's profit or non-profit. Because it sounds like you could have a for-profit hospice that might do a better job in some cases than a non-profit hospice. So that's not an easy way to pick, it sounds like. Yeah, somebody else had a question. I think Faye, I see in the back, she's got a question.
Chances are that I would be using VSED or the End of Life Option Act to hasten my death, and I will want some home health care or home care person with me, but I don't want anybody who's gonna make a big fuss about that, or whose religious principles can't stand the fact that I'm making this choice. So how do I screen out those people who are not willing to work with me if I choose to hasten my death?
First of all, there are only 2 home hospice companies right now in San Diego that do the Right to Die Act or follow it, and that would be Silverado and I think it's who? Intra, maybe? No, not Intra. No, not Intra. No, it's Silverado, and there's one other company. Apriva. We're as of right now today, we're the only ones that do it. As far as, I'll let her speak on caregiving because that's yeah.
Okay, so what I think is important right now, before the crisis occurs, there's 3 people that you're gonna have in your home, most likely at end of life: hospice, home health skilled, non-medical home care. So what you wanna do now is look at, with not necessarily non-medical, but the other 2, one of the things you start with is your insurance. You know, which ones does your insurance take, or who's your medical director for those 2, and then do your evaluation and come up with your top 3. And same thing with home care. Interview and then come up with your recommendation for your top 3. Now you have to update that I would update it every year and a half, even though you're perhaps healthy and doing well, just so that, because people go out of business, people change staffs, and things change, so continue to update that. But real quickly, so when my dad left the hospital and was hip surgery and was going into a skilled, my mom calls me and says, oh, your dad's going so-and-so. And I said, what? I said, did they give you a list? Yeah, they gave me a list. And I said, how did you choose where he's going? And she said, well, I chose the closest one to my house. I said, Mom, are you kidding me? I said, that is the worst you could ever. I said, give me that list. And I told her which one was the best one on the list. And he went there, and he had a wonderful experience and thinks our healthcare system is the best ever. He would not be singing that song if he went to the one she had originally picked. So go there, tour, interview, come up with your best 3 for all 3 groups, and then update them on a annual basis.
Any other questions? Lady Reynolds.
I'm not sure I understand the concierge care. Could one of you just quickly review that? Because I got down here $1,500 to $3,500 a year.
Plus visits? Is that plus visits?
What?
Sorry. So there's, integrated health is different than a standalone concierge physician. So she'll talk on that, that's totally different. A concierge physician charges an annual fee. There's many throughout San Diego County, and I just gave you an average of what I've seen, $1,500 to $3,500 a year, and then they can bill your insurance for healthcare services. But it's just so that you have access 24/7 to a physician, phone calls and such.
There's a second option for in-home palliative care, which is integrated MD care, where I work with Dr. Bobby Uslander. And we work outside the insurance model, so we're private pay. So for anyone that can afford concierge palliative care, you get access to our medical team, which is Dr. Uslander, myself, who's a registered nurse, a social worker, and we also have office support staff. And we're all on call 24/7. And we can make many more visits than what's allowed by insurance and really provide that high-touch, highly personal, in-home medical care. We even follow our patients to the hospital and help oversee any services they're receiving at the hospital through home health, through hospice, through caregiving agencies. And Faye, to answer a little more on your question as far as caregivers that would be supportive with End-of-Life Option Act or voluntary stopping eating and drinking, you can ask us, we have a list. But one important thing is to just be upfront with the hospice and with the caregiving agency as to your plans, and they'll naturally weed themselves out.
But would you talk about the cost, please?
Yes, please. So through integrated MD care, the cost varies depending, because it's highly personalized care. Some patients that just need a weekly nurse visit or a monthly MD visit may pay $800 a month for the visits included and 24-hour access to our team via call, text, email. Or we have patients where we're essentially bringing the intensive care unit home because they want to get out of the hospital and be home with their family, where we are seeing them multiple times a day and spending hours coordinating their care, and that can be $4,000 a week. So anywhere from a low level of cost to a very high, depending on what kind of care you're looking for. And we will also bring in hospice agencies to offset that. So if someone wants hospice, we'll allow the agency to make visits in addition to us, so we can charge you for less visits. Same with home health or any other outside medical care that is covered through insurance. So we take all that into consideration when it comes to the cost of the care.
Let me touch on that. And the only way you can get hospice and palliative at the same time is if you pay privately for palliative. You can't bill Medicare for both.
Any other questions? Michael, you have another one.
Well, I've had both a good experience and a bad experience. The good one was with my brother.
Michael, if you hold that a little closer to your mouth.
The good experience I had was with my brother just last week, and hospice was very good, very attentive, etc. At that time, he was in an SNF already. But a bad experience was one where a member of this organization, a Hemlock member, was in her home. And the hospice at that time was, was, I guess we'd say, overburdened. One of the problems was that although she definitely was terminal with one of her cancers was in her gut area, she had a loss of control of her bowel, and so at times this made a tremendous mess in her bed. And originally, since I was the healthcare agent, I would call the hospice, and they came and they did, I thought they did wonderfully, but that happened one time, and when a few weeks later it was a second time, I call their managing director came and chewed me out, saying that this was my responsibility, it was not theirs. And so I should be cleaning up this mess or hiring somebody to do it. So I was quite kind of alarmed and shocked by this, because I felt at least the incontinence was caused by the terrible cancer she had in her gut. And I thought it was part of it. But obviously the manager of the care of the hospice was seeing that this was way too expensive for them for the amount of time that it took for this cleanup to occur. So I just wondered, is that considered non-medical? That's what really puzzled and shocked me. And by the way, he told me he was going to report me for negligence of this patient if I didn't clean it up myself.
I'm so sorry that you had that experience. That is really sad. Let me explain what hospice does do. You do have access to a caregiver. As Jennifer said, every hospice runs differently. You want to find a hospice up front, like she said, interview 3. Find out what that looks like as far as caregivers go, nurses, doctors, how many visits up front, because many hospices will do the minimal, we don't. Regarding that situation, a caregiver does go out, I'll speak for our company, twice a week for about an hour. If your loved one had an accident on her off day, and you called us and you needed support, we'd come out, but that's not routine. Hospice companies don't go out, they're not paid by Medicare to do caregiving beyond that. We get so many hours. Will we go above and beyond? Yes, I've seen it, our company's amazing. However, again, Medicare has standards and we fall within that. So nurse twice a week, caregiver twice a week, social worker anywhere from once, what would you say, twice a month? Once a month. Chaplain can come out, how often did you see? Once a month, if not more. But no, Medicare, am I right? Medicare doesn't pay for caregivers.
Yeah.
They usually combine our care with caregiving agencies.
Yeah, at that point, like Lori said, Medicare will only pay for so many visits from the home health aide or caregiver. So that's when you would want to bring in caregiving services if you're needing what's above and beyond that hospice can provide.
Correct. And so they usually pick up the supplies and that will be paid for, but no one knows when someone's going to, go to the bathroom, and so you can't have someone there 24/7. And the bottom line is our HMOs, this caregiving services is not covered in that. It is basically private pay. Can I just say one thing though that I forgot to mention earlier? There is one other program that is awesome and it just started in February. However, it's disease specific, but it covers a lot of disease. So if you are someone caring in your home for someone that has dementia or dementia-related illness, which would cover, quite a lot, Parkinson's and whatnot, usually you're going to have a high care need, right? Someone like that, it's 24/7. And there is a new program that is given $1 million a year. It's actually going to roll out for 5 years, so $5 million. It's a match program. So you're really talking about $10 million because it's going to match what the client pays. So what they have done is they said if you have this disease, okay, you can call one of the contracted let's say agencies is Southern Caregiver Resource Center. How many people know Southern Caregiver Resource Center? So it's not a home care agency, but they then contract with 3 home care agencies. So what they'll do is they'll administer the voucher program, and the way it works is they have, under the program, it came in at $27 an hour, so you, the client, will pay half. You would pay $13.50 an hour for licensed non-medical home care, and the $1 million that funded this program will pay the other $13.50 an hour. There is no financial requirement. That's huge. So they don't care what you own or how much money you have in the bank. Okay, so if you know somebody caring for someone at home with that disease, tell them to call Southern Caregiver Resource Center and you can get enrolled in the program. It's a voucher respite program for that chronic disease.
I can see our time is just about up, so I'm afraid we're going to have to wrap it up. We have to be out of here, I think, by 3:30. And so we could go on, I'm sure, but in any case, thank you so much for coming. And if anybody wants to pick up any of the literature, there's plenty on the back table from, I think, each of the participants. And of course, there's little